So not taking too much of time, I'll leave that part to Dr. Varsha to ponder upon. So Dr. Varsha will be moderating this session. Dr. Varsha Purade is an MBBS, DA, DNB, FIPM, and she's also the director and program head at our FIAPM. She's a GC member of ISSP and as well as the past secretary. She works for KK Care Hospital in Pune and Indrani Cancer Hospital and Research Institute Pune and Maimar Medical College Pune again. Dr. Vaishali has a lot of publications to her contribution. She has also been awarded the best poster presentation in IASP Con 2024. She's also awarded fellowship. She has an of course fellowship from IAPM, and she is a regularly called examiner for the exams, and she's authored quite a few chapters in FIPM manual as well. She has a lot of publications and papers to her credit, both at national and international level. I would leave the rest of the class to you to moderate. So over to you, Varsha. Varsha.
Thank you, Dr. Fateh, and that was a whole lot of introduction. Okay. Sidharth, I really want you to display your TV PPT slide first.
TV?
I am definitely able to introduce Sidharth beyond his, on paper accomplishments.
हम सीवी तो बनाया नहीं मैंने निकालू क्या
नहीं बनाई ना मुझे लगा ही तेरी होगी वो 10 पेज की होगी अलग से रखी होगी वो
नहीं 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 मैम यस मैम
right so just to keep it brief and short for Sidharth, he is one of my favorite speaker, researcher, academician, entrepreneur, and very talented physician, pain physician especially. And I got connected with Sidharth on common ground of how our branch, pain medicine, needs to be acknowledged, needs to be recognized, and what it will take for us to forward this branch, to spread awareness, and how we can expand our community. Like you all are FIPM candidates, most of you. And this is what we have been always discussing all the time. Like Sidharth was ISSP GC member as well last year. So, yes, thank you, Khalid. And somehow I'm not comfortable looking at black screen in front of me. Somehow I'm not able to interact with black screen. So, if I can request all of the candidates, students, practicing pain physicians to be on screen, it will really help you keep your attention 100% here. Okay. So Sidharth is also program head running fellowship at D.Y. Patil Medical College, Mumbai. And he has got his private practice, his own clinic. And he has been conducting a national conference every 6 months called MIPSICON, which is coming soon, like right away this weekend. And this is who Sidharth is. Okay. All the time interested, curious, learning, innovating, and spreading pain knowledge. So, Sidharth, over to you. Hi, Dr. Khalid.
Great. So thank you very much, ma'am, for the.
How are you all?
Hi.
Yeah, all are great.
Yes.
I'm answering on behalf of them as no one is coming on screen, and probably we can't unmute all of them so as to avoid disturbance.
See, have you seen us? I'm so much sincere in that.
Yeah, I get that. Okay. Yes, many faces are showing up slowly. Okay, Sidharth, over to you. Without wasting time, let's get back to the topic.
Yeah, okay. Okay, so let me start. Just share my screen. Okay, let me know when you can see my PowerPoint,
Yeah.
and let me know when you can see it full screen. Can you see the full screen?
No, it's only the screen view, multiple slides view. Yes, now it's full screen.
Okay, great. So I'm going to cover the Stellate T2-T3 sympathetic, and this is one of my favorite topics because uh, I started this Stellate was one of my first procedures when I was doing my MD. So now I have come quite, I think, maybe 15 years after I'm doing this T2, T3 exclusively. And I'll tell you my experience as well. And I'll tell you why, when to do Stellate, when not to do, etc. Greetings from Mumbai, where I now stay. This is D.Y. Patil Hospital, where I work. I'm a professor in the Department of Anesthesia, and I am the mentor for fellowship in pain medicine program here. And this is our some of our past fellows. This is last MIPSICon when we met. Those bottles are not what we drank, so just relax, guys. So I'll go through as requested the anatomy, indications, technique, experience, pitfalls. But I'll try to keep it very simple and precise. And there's very less literature available on this topic, especially T2, T3. But this is something which I'm doing for the last 7, 8 years now. So pretty, you can say, decent procedure which has survived my hard private practice. So I think you all should learn. So this topic matters because CRPS and ischemic pain and sympathetically mediated pain, they remain difficult to treat conditions, and many procedures fail due to poor anatomy and understanding. Uh, T2, T3 contribution is often ignored, and modern images has improved safety and accuracy a lot. So I'll start with the stellate ganglion procedure. So stellate ganglion, as we know, is a procedure where we're going to target the stellate ganglion, which is formed by the union of C71 ganglia, and it was initially done with landmark method, where we used to insunate our fingers and push the soft tissues around and kind of just deposit our uh, needle tip near the bone, and then we used to just check in the C-arm after giving dye, making sure the needle does not move, the tip doesn't move, which was very difficult, but we somehow did that, and then we used to give the drug. But now with the advent of ultrasound, it's one of the safest procedure. You can see each and every structure. I'll show you. So before we begin, this is a simplified version. So you have, I'll just use a laser pointer. So you have this C6, C7, T1 vertebra, and this is your target, and it is a sympathetic ganglion. So the fibers which are going from here, they are also going up as well as down, and I'll go through indications and all as well. But we're going to target them and block them for a temporary relief. And there's a detailed anatomy showing a lot of structures around. So mind it, the thyroid has been cut on this side to expose the structures below. So this is the thyroid gland. And if you see the midline structures, you also have the trachea. Then if you reflect it, you have the esophagus. Then you have the vertebra as well. And you have some muscles like the sternohyoid here, which are originating from here. You have a lot of nerves and vessels going all around. As anesthesiologists, you are used to cannulating the jugular veins. So you are familiar with this structure. This is familiar territory. So I'm going to focus on the relevant parts only. Just an overview of the sympathetic innervation, only the relevant part. So we have the cervical sympathetic ganglia, and this is the sympathetic outflow, which is uh, shown here, and you have the superior, middle, and inferior ganglia, and you can see the proximity with the T1, T2, and T3 ganglia. And I'll tell you why that matters a lot. In addition, on the left side, if you go just slightly down, you have the T2, T3, T4 giving the supply to the heart. And if you see, you have the cardiac and pulmonary plexuses, which greatly intertwine. So there's a lot of connections here. Tough to kind of remember as well, but you can just start with remembering that it's complicated. The next time you remember what it is. So from the pain perspective, I want you to remember that we're going to target the stellate ganglion, which is here. And then we are also going to target the T2-T3 sympathetic as a part of the sympathetic chain. I'm not going to cover the other stuff. Okay. So this is the basic approach. I'm going to share the structures around for the T2-T3 approach. So the ideal is if you go to T2 as well as T3, but when you're giving the drug, it doesn't matter actually too much because the drug is going to spread. At the thoracic level, the sympathetic chain is a little posterior than at the lumbar level. Lumbar level, you'll find it here. It's quite ahead. And at the splanchnic level, it is somewhere here. So the mirror image will be splanchnic. So where the chain will come here. And then if you go further down, your chain will come ahead of the vertebra. That's why in the lumbar sympathetic, you'll take your tip to the anterior margin. So this is a junction of the anterior 2/3 and the posterior 1/3, or the ventral and dorsal 2/3, 1/3, and that is where we want to target. And how you target is you are going to go very close to the vertebra and making sure you don't puncture the pleura. And a rule of thumb is start 4 centimeter, but then you also have to see the patient size. So I do these procedures in a cath lab, but I have done it in CM also. So it's not a contraindication, but the clearer the picture, the better it is. So whenever you do these procedures, try to make sure that you have seen the vital structures before. And first time when you do it, make sure somebody's around who's done it multiple times, preferably. So, so I think I'll go continue with the anatomy first. So stellate is a fusion of cervical and thoracic ganglia, and it supplies head, necks, and arms. So slight variation occurs in individuals. So I'll just generalize the things located near C7T1. Although you are going to hit the C6 one, so you need your drug to travel down. That's very important for us to understand. T2, T3, they supply the upper extremity and thorax. So if your patient is having CRPS, makes more sense to do the T2, T3 one. And it's an old procedure with new possibilities. Sympathetic system controls the fight or flight response. So you're going to have the involvement for the pain, CRPS, and vascular involvement. When the vascular symptoms predominate, that's when you get good results. And in addition, T2-T3 has been targeted for hyperhidrosis and now explored for the post-traumatic stress disorders, long COVID, and more. I will discuss on that a little later. So the mechanism is sympathetic blockade effects. So there is a reduction in norepinephrine levels, which leads to vasodilation. And the Horner syndrome was used initially as confirmation, but now we don't want it. There is a central modulation also happening, which is especially important in post-traumatic stress disorders and long COVID. Now this word is used less often, so you can say chronic fatigue syndrome or something like that. So pain relief is via the flow stoppage and the neural reset that happens. So for the stellate ganglion block, you need to make sure you master this anatomy. So while you are scanning from top to down, you see the C6 transverse process pipe bed along with this root coming out, and then you go to the C7, which is like a cliff, and the sequence is important. You're coming from up to down, and on your screen you will see something like this just near the C7 body. So this is the longus colli muscle. You need to find a plane for your needle, which will be your path, and that's how you want to take it. You also see this thyroid, which is very easily differentiated. It's a grayish ground glass appearance structure, and your needle comes in just missing the vessels. If you feel you are too close, just inject a little bit of saline or D5, whatever you prefer, so that you reach your target. You need to reach on near the longus colli muscle, and you need to puncture the fascia, and otherwise your drug will all be wasted and you are at C6 level. I repeat, the reason we do it higher up is because of the safety. However, with ultrasound, you can go even down below, doesn't matter much, okay? And this approach is very, very common. Just a minute, and just adjust my slides a little bit. I think I somehow just again let me know when you can see my screen, and let me know when you can see it full screen. Okay, so I have explained this. Now you see the C6 approach is safer. We are going ultrasound guided, and we usually put in 5 to 10 mils of local anesthetic near the longus colli muscle. We look for Horners and warmth, especially when using such high volumes. Uh, there is a lot of options. You can find some good literature also for neurolysis, etc. What you can do here. This picture I've already shown. So now comes in the T2-T3 sympathetic technique. So I've already explained. The key here is that needle should approach under the head of the third rib or the second rib, wherever you are targeting, and with the tip approaching the T3 ganglia of sympathetic trunk. So you're going to come like this from here. I'll just draw it for you, and you can see you are coming from here, 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 and that's how you're going to kind of reach here. And this is very important for you to understand, because you need to position your CM or fluoroscope or cath lab equipment in such a way that your radiation allows you to visualize the path where you want to go. Okay, so coming uh, to the cut section, if you see from top, this is already very amply clear. And if you see here, this just focus here. So you take a picture wherein you are, you know what's a midline, then you start around 4 centimeter away, and you target is this ganglion. So you have to reach the junction as mentioned here. So whenever you do any procedure, you imagine a 3D section of the patient, and you check with the fluoro in both AP and lateral views. The best will be if you can find a biplanar cath lab, where probably I do my procedures in a biplanar cath lab, so I can see both the views while my needle is going without moving anything. So I'll just say picture, and I'll see AP lateral both, and the patient lies, of course, prone. So this is very important, because you need to check with your patient whether they can lie down prone before or not. Otherwise, you can't do this. Uh, then the typical RF ablation protocol, you can go with 80 degree 90 second, or you can add phenol. I have not put alcohol or phenol here. I've always used RF here. That active tip is uh, 5 mm or 10 mm. Don't use bigger tip, and use the standard one here. Uh, if you want, you can use a cool one, but that's quite risky. And the problem with the cool one is you cannot bend the tip, because it's a 17 gauge needle. So you should not attempt on that here. The goal here is a permanent blockade, for which you either need a neurolysis or a thermal neurolysis, so chemical or thermal neurolysis you require. And I'd prefer if you can take a infrared thermometer, which is handheld, or you can also check with warm hand on the ipsilateral side. So, of course, Horner's confirms a block. There's a risk of hoarseness, numbness. Rarely you can have pneumothorax. Even seizures have been reported. Uh, Neurolysis can lead to long Horner's as well if it's a result of the RF rather than, say, your local drug spread. But it's quite safe when properly done. And I want to draw your attention to this set of fibers known as Kuntz's fibers. They're anatomical variations of sympathetic nerve fibers that connect the second thoracic nerve to the brachial plexus, often by bypassing the main sympathetic trunk. So that creates a lot of issues because they can be the reason of failure of your procedure in spite of good technique. So in anatomical and cadaveric studies, some people never found it. So they did cadaveric study and they never found the Kunz fibers. So around 20% of studies they didn't find it. So the difference is because they are quite tiny, delicate, and difficult to visualize because they have low color contrast, meaning they are frequently hidden under the pleura during the surgery also. So even if you operate live patients, still you can't find many times. So that's very important. Here, mind it, this is not the actual color in the body, so it has been colored for your benefit. You can see here, and this is a kind of ink which colors it, and you can see that. So the important point where I want you all to draw your attention to is that there are a lot of emerging uses beyond traditional pain indications now, which are available for us to see. For example, as I mentioned, we have the post-traumatic stress disorder where anxiety and hypervigilance are the predominant symptom, where you can actually use this as an off-label use. In addition, you can use this in fatigue, brain fog, patients who come and comment, these symptoms. You can offer that diagnostic procedure to try, and if that helps, then later on they can actually uh, use the uh, use the procedure to gain control. In addition, I have done in many cases of refractory angina with good pain control. This is one of the very good indications because cardiologists are everywhere now. So there are a lot of patients who go with chest pain to them and go to them and tell them you're doing this procedure. And I'm very sure that we'll get a lot of patients from them very soon. Uh, Non-surgical treatment for hyperhidrosis is another thing which is going to be very important when you treat. And these patients will be all around. In fact, maybe there are 40 people here. So maybe one of us also has it. It's very common. Then comes the phantom pain for the only for the component of sympathetic relief. So this is very important. When we explain to the patient, we must tell that this is going to cause only sympatholysis. So phantom pain has a lot of other components which you need to take care of, especially the central component, the stump pain. That is not going to get better with this procedure. So I'm going to take these one by one. So what happens in post-traumatic stress disorder? You can reset the autonomic balance. You can find some RCTs of 2020, 2030 patient. There was a drop in the PCL score. Bilateral SCBs were preferred, especially as a diagnostic criteria, and there was a long-term symptom relief in these patients. So let me ask you, would you consider stellate ganglion block for post-traumatic stress disorder? Type in the yes in the chat box if you would. So I think most of you didn't show your face, so I think you can show your fingers, guys. So just type in the chat box so that I can just see. Okay, yes. So already two yeses. I think same guy. No. Uh, okay, yeah, four awake from 39. Okay, 5, 6. Great. 6 on 39, 7, 8. Okay, people are getting up, waking. Oh, yes. Wonderful. 9. That's it. Okay, anyway, so let me take you ahead. Uh, Maybe C was also an option if other fails, but then definitely I'll say yes if patient comes and just those of you who are in research institution can do more of these cases, and maybe one guy got up. Okay, Dr. Vidya, thank you. So now comes to the long COVID, which people still do come with all this, especially in the affluent class. You have these symptoms. Usually not seen in people who are not very affording. So dysautonomia post-COVID was common. Now this is transformed into a post-viral illness or generalized fatigue. And you'll be surprised, 86% of these patients had relief, better smell, less brain fog. And one of the studies had 41 patients with more trials underway. Thank you guys. You sent me a lot of money also. So, so going to the refractory angina, there is a reduction in the sympathetic drive, which leads to less angina. And you use the left SGB and then follow it up with a T2-T3. It reduces ischemia and VT. Many times I have been, in fact, there is a good um, evidence in the even in the cardiac literature, and you may be called many times to do this procedure, but then this has to be emergency. So whenever they call, be sure to reach there in like 3-4 hours or 5 hours and then do this procedure, because otherwise they will cancel the call and you won't be able to help the patient. So the evidence supports improved tolerance. With the hyperhidrosis, go for T3 for sure. With the RF in one of the uh, literature which I read, the success was 100%. It's low compensatory sweating, and T3 is preferred here over T2. T2 very important. Okay. So for the phantom limb, so very surprising that people were giving regular sympath this slit ganglion blocks every week or 2 weeks or something like this earlier, because because these patients were having severe pain and always used to get relief. So now we're fortunate that we've got RF, so we can do this RF. And many people have tried PRF in Stellate, but I have all my doubts, because as you saw that the result is because of the diffusion of the drug, and especially if done at C6 level, so the efficacy is dubious. And but in one 2024 study, they found the reduction in NRS with long-lasting review relief. So for the sweat disorders, we already have two RCTs with reviews. With long COVID, we have stuff already there. With the cardiac, it is established. With hyperhidrosis, with phantom, we have PRF studies, etc. So we have some PTSD cases published with CRPS and phantom. It's routine. Many physicians are doing it. But for the hyperhidrosis, still the evidence is emerging. Very important. You need a psychiatry collab for this. So whenever you meet your psychiatrist friend next time, just be sure to talk about PTSD and the role of this procedure there. And I'm very sure you'll get a lot of these patients. Again, time to wake up. Okay, I think 9:30 is a good time. Uh, so if a patient comes with hyperhidrosis, what is the best next step? We do a surgery, then we do a RFT3 neurolysis, or we do Botox, or we do wait and watch. So guys, just type in the chat box so I know you're still awake. Oh yeah, yes, all B's. I think, yeah, good. Now quickly coming. Yes, wonderful. Excellent. So I think you know now what I mean. And now come to the phantom limb pain. I think I'll talk about the upper limb here because we are focusing on the upper extremity neurolysis. So the way to manage uh, SGB is only a small role here, very important. And you need a multimodal therapy. This is very, very important for you all to understand. So don't promise, over excited results for these patients because of the single procedure, it will have only a partial relief because that component of pain, which is mediated by the sympathetic fibers, you will be taking care of. Okay. So I think we can have a discussion on this after I end. So for these procedures, now what I do right now, I not a fond of stellate ganglion neurolysis, so not a fan here, and I will do a diagnostic if required maximum because it's a very easy, simple procedure and place your ultrasound there, just give a diagnostic drug and ask the patient how much relief they have, and then go with T2-T3 RF at both levels. You can also use these procedures. The key learning point which I wanted to drive home today was that in addition to the CRPS and the hyperhidrosis, which people are very commonly using in India. You can also use this for post-traumatic stress disorders, uh, COVID or general fatigue, post-viral fatigue, if somebody has. Then for cardiac indications, and of course, as I mentioned, for sweating. And this is a lot of data is emerging and safety and access is improving. So collaborate across specialties to get these cases which nobody is treating. So maybe your practice. I think with these words, I thank you very much. As I would request you all to visit Mumbai and do join our workshop, MIPSICon, which is in its fourth edition. And I see you sometime soon. Thank you. Nothing.
To the point, very great and very informative lecture, Sidharth. And your quiz in between to have a check if all are alert and awake. I liked it.
Thank you, ma'am. So I think
Okay, so
if
yeah,
you have any
any
questions
questions?
or comments from the seniors or faculties whoever is there.
I would like to have questions either in chat or yeah. So there is one question. Sir, if stellate ganglion be blocked bilaterally, what should be the interval? Right.
So I mean, we don't need too much of an interval, but then the thing is, you are concerned about the cardiac fibers probably. Is that your concern?
Must be because you mentioned bilateral stellate for PTSD. So
Yes.
exactly that was my concern as well
Yes. So the
on this
thing is,
platform.
not on the same day, of course,
Hmm.
because you don't want to give the patient a risk of, even if it is a theoretical 1% risk, and after the procedure you get something which you don't expect, that's going to be tough for you. So maybe on separate sittings, there's no specified time interval, but then definitely you can also use a shorter acting drug to see how they respond. But if you see for the post-traumatic stress disorder, um, you have to give a bilateral one. Okay, so I will not do a bilateral one immediately, but then definitely uh, with a time interval. Okay.
What is the time interval, like you said, in terms of hours, depending on duration of local anesthetic action or days? Is there any
So you
literature
first
if you have
start with,
searched?
look, whatever they have done, if you see, you first start with the with the right side, and then you can do for the left side. Ideally, on the next day also you can do that. It's not a problem.
Right.
And uh, uh, if you want, you can do slightly early also. But then you need to be using the specific protocol, and especially if you can refer to somebody who's already done it, the literature is already available. So use the same protocol. And then after you've done 5, 7 cases, you'll gain confidence, and then things will be much easier.
Thinking about bilateral stellate all the time, like whatever may be the indication. Again, next question is about that. Shalaka is asking about whether it will work for bilateral burning in hands. But one thing I would like to highlight here, for whatever is the indication, performing bilateral stellate is definitely going to come with a set of cautions, just like how Sidharth mentioned. So don't take it as a blanket statement like bilateral stellate ganglion block. It has to be very cautiously planned and performed with utmost precautions and not at all doing at the same time bilaterally. That's what you mentioned, right, Siddharth?
Yes.
So
Yes.
what is this burning in hands, like bilateral burning in hands?
Bilateral burning in hands also you can use. Yes, you can of course use. So the thing is, you're going to diagnose. Now, of
Exactly.
course, if the cause is, you need to check what's the cause. I'm just posting one link. You can go through for the bilateral for PTSD. This is the study which I had referred to, and if you can see, you will get a lot
Okay,
of.
you have posted a link, okay, in text chat box. Siddharth has posted a link. You can refer to the article.
Okay, so they've done
Yeah.
like maybe more than 40, 60 cases. So good evidence. So nobody will put you, it's not experimental. So you
Right.
have some evidence. So don't do experimental stuff. For the burning, again, you need to have a good diagnosis. If you feel that you exhausted other options and now you are suspecting that mechanism that is sympathetically mediated, so definitely you can try. There's no harm.
When the description is burning, mostly the alarm which rings in our head is it is more likely sympathetic or centrally
Yes.
mediated pain.
So
That's why
slow,
probably the
dull
caution.
type of pain, burning pain, will be mostly sympathetically mediated. Sharp
Yeah.
shooting kind of a pain usually is not. It will be better.
Yeah. And this being like daycare procedure, like USG guided diagnostic procedure, there is no harm if you explain the patient all the pros and cons, and it is being diagnostic, not definitive procedure. As Siddharth mentioned, if you have ruled out other causes, you can take it on. Okay, Shalaka? Any other questions? Afan. Okay, since Kunz fibers can bypass the stellate ganglion, should T2-T3 sympathetic block always be preferred over stellate ganglion for upper limb pain?
Yes, but then you have a great ease, of and safety of the procedure here. You just
Hmm.
patient lies down, you are in your clinic, everything is chilled. You just sit one nice needle and you're done. 10 rupees stuff, I think. One needle and one this thing, some jelly comes cheap. So you have successfully done it. Now going for the T2, T3, you have to go to the Siam or preferably, that's my choice. Of course, it's not a necessity, but go to a nice swanky cath lab with biplanar mode, and you do a diagnostic stuff. So it doesn't make sense. I would never do a diagnostic T23. I will always do a diagnostic stimulate if required.
Hmm.
I'm not a fan of diagnostic procedures where the cost to the patient is too high.
Right. So usually we do diagnostic stellate, and if you have 50% pain relief, you can go for T2, T3 sympathectomy directly, right?
Yes, and mind it, you have to explain to the patient that even after a positive diagnostic, your procedure can fail to give them relief, because otherwise they will say, oh yeah, doctor, you did it nicely first time, second time you didn't do correctly. So you are responsible for the failure. So that is very important. And second is the target is slightly different. That also you have to explain, because now you are going slightly down below. So whenever it's upper limb predominant, you can go for T2-T3. So that will give you good results. So CRPS you can't do with one sitting of SGP, definitely not. And if you want to keep on doing repeatedly, that's one option. So keep on poking, keep on doing. God is great. Things will be better. This was done earlier by many of our seniors for lack of resources. So if you are in a setting where lack of resources are there, please go ahead. But then if you are in a place like, for example, Mumbai, so when they say lack of resources means you are on a hilltop and there's nothing around. We don't mean that you are, one on one side there is Medanta, other side there is some other big hospital, and you are sitting in your hut below, and you don't have the ultrasound. That doesn't mean. So patient has to be given an option of the correct treatment. That's very important. So in remote settings, of course, you can do it. You are in Siachen and you want to just use a needle and you have ultrasound, so you can do it. But then definitely not in a this thing. So diagnose with CRPS with sympathetic component with SCB, and then do a T2-T3. That's I think the way to go.
This is an interesting question. Bilateral stellate ganglion block. How significant is the risk of
Of course,
recurrent
it
laryngeal
is actually we missed this thing, but definitely there is a risk of respiratory compromise.
compromise?
So this you may need to ventilate the patient. For bilateral, there is always a risk. For unilateral, because look, you are given the drug, so it can go to the recurrent laryngeal nerve. So there's always a risk, and
So, wait, on the same point, I would like to highlight bilateral stellate is more of a theoretical description. None of us is doing bilateral stellate in
daily,
any condition. Okay. I'm sure
daily.
all the audience who are practicing here will agree with this. So I'm just sensing there is a lot of attention towards bilateral stellate. So the
Yeah, tomorrow
message
don't do a bilateral
here,
slit.
yeah,
So I
is
think
we don't do bilateral stellate. It's more of a theoretical description. And obviously, there is a risk of all narrated complications, but we are doing image guided procedures and our patients are awake. The moment you touch some nerve, the moment you are near critical structure, you are either visualizing it on the screen, USG, CM, CT, or your patient is totally awake and interacting with you. They will definitely communicate if you are touching some sensitive structure. So, by and large, our procedures are safe provided you are completely aware about what is going around, right? Siddharth, you can add to this point as well.
yeah, of course. And most of these studies you will find there a couple of studies there, and they have done it 24 hours apart. So
Right.
that's also bilateral means not on the same time. Like today you don't do it. You
Yeah.
always do it like one day apart. One guy has mentioned 12 hours, but that's too early. So today you do one, maybe after 2 3 days you can do one more, or one day also you can do. So read this link which I've shared here.
Hmm.
Afan wants to ask something. Unmute.
I have one question regarding Kunz fiber, sir, basically. Sir, you said we gave the diagnostic block for stellate ganglion first, and then to diagnostic block to stellate ganglion, and then if it is positive, then we go to T2-T3 sympathetic blocking.
No. That's not we do. That's what I am doing in my practice, because I find
Okay,
it appropriate. If you have given a stellate diagnostic, what you should do next is do a stellate neurolysis
okay.
by the same way. And why I don't do it is because I don't want a Horner's going up. So
Hmm.
my action comes when my drug seeps in down and not goes up. So
Okay.
I am trying to be more focused and I'm doing the T2-T3. So this is what I am recommending to try for some of your procedures, but that's not what should be inferred in a general term that हाँ हम सब में ऐसा कर देंगे. So if you do a Stellate local, then do a Stellate neurolysis. If you do a T2-T3 local, you do a T2-T3 neurolysis. That's what should be done. So what
Okay,
I am
fine, sir.
doing is, because T2-T3 is tough to do, I want to have some kind of a diagnosis. I give a 5 to 10 ml volume so that it seeps down. I'm focusing on my drug going down rather than up. And then I'm going to do a T2-T3 neurolysis because stellate ganglion is tough to manage with the RF. And I don't want neurolysis with alcohol because I am scared of the long horners. Okay.
Yeah. Thank you, sir.
If you prefer in select volume and concentration.
Yeah, so I already told you. So like it's a 5 ml is something which is there, but you can go more also. Like the volume can be increased, especially if you don't get a spread upwards. You can do this under fluoro. You can just put with ultrasound. You can put the needle, then you put the dye, mix with whatever drug you want. You can take a shoot also, see where it is going. You'll come to know where it
Prefer
is.
like preservative-free lignocaine
Yes.
percent.
Yes, of course. Always recommended. I never use the xylocaine. I always
Regular,
use Xylocard. I mean, as a
yeah,
brand. So I mean, I never use
right.
methylparaben as a preservative. So
Yeah,
I for anything I don't use at all. There's no xylocaine
yes,
or in my ever in my list.
true. Same here.
Wha-
Xylocard, right from local skin subcute anesthesia
So
till
even if
the
there is a 0.1% incidence, I don't want a risk of because I have done I think I calculated around 4,000 procedures. So out of that, 4 patients would have suffered already. So I don't want any risk. Whatever minimizes the risk, that will do.
which is better, pulse radio frequency or he must be wanting to say conventional radio frequency.
Yes. So always conventional is better. Pulsed is used when you want to preserve the structures but still cause the intended effect. So the mechanism is entirely different. But the variation in the result is because our thermistors, which are at the tip, they're not very sensitive. You think they are giving you correct temperature of 42, matlab 42 yoga. It's not like that. So the temperature might go rise. So if you read the literature of Sluger et al. Or Sluer, whatever they call him, so you'll find a lot of pulsed. Many of my senior colleagues are a fan of pulse, so you can learn more about pulse from them. I personally don't do pulse anywhere. Even if it's a mixed nerve, I'll prefer a low dose RF than going for and that is continuous or thermal RF than going for pulsed. So for theoretical purposes, pulsed is different. Standard or thermal RF is different. Pulsed indication where you have motor component, where you want to preserve the nerve, and where you want to destroy it completely, you do the thermal standard RF. Okay. I think I should give like this. So book answer, that's Verma answer, like that. So you
Yeah,
don't
the
generalize
practical.
things. So I understood.
Okay, perfect. I guess that is a lot of coverage and all the questions are answered. If no other questions, can we close the session, Dr. Swati? Right. So, Sidharth, once again, thank you.
Thank you,
And
ma'am.
it was an excellent revision for me as well after so many days. One of my uh, favorite blocks in the beginning days, like stellate ganglion block.
As I
And
told you, this was the one which we were also doing regularly
exactly,
because this was
very
very
common.
common even in anesthesia practices. So
Hmm.
we'll just put a
Right,
finger and just do it and then run away.
true. Okay, so let's wind up and all the best to you all for your next series upcoming lectures.
Great. So,
And
same greetings from me. Keep learning, guys, and always stay safe. And do not overcompensate for the faulty technique by giving more drug. So that would help. Bye.
okay, bye
Thank you,
bye. Good
sir.
night.
Bye.